A very good morning, good afternoon, good evening, everyone, from wherever you are from, and welcome to this webinar. Today we are talking about sexual well-being in neurodiverse and neurological patients. So just as a reminder, if it is your first time to attend the webinar, the ISSM webinars now have the option to add automated subtitles, including translations. You will be able to turn this on and off at your convenience. You can select the language of your choice via your own screen. To do so, at the bottom of your screen next to the chat and QA, you will see a third button shown here, show captions. Please click this button to select the language of your choice. So my name is Joachim Osur. I'm moderating this webinar today. I'm from Kenya. Maybe a little about me. I'm currently the Vice Chancellor, AMREF International University, which is a Pan-African university based in Kenya. I'm a professor of sexual reproductive health and public health and a sexual medicine practitioner. I do my clinics here in Kenya. I think I'm the only doctor currently providing sexual medicine services in our country, but we have many sex therapists as well. I'm very interested in how we can use the African practices to improve sexual medicine because there are many unstudied practices here in Africa which could be very helpful in improving sexual health. Let's move to the next slide. So ISSM vision is that because every human being has the right to a healthy and satisfying sexual life, that is our vision. We exist because every human being has the right to a healthy and satisfying sexual life. Next. And our mission and purpose, our mission is to become the most respected and trusted source for information, education, and professional development in the field of human sexual health. We achieve this through the delivery of world-class publications, research findings, and both online and in-person opportunities for knowledge exchange worldwide. Next. So there are affiliated societies of ISSM the world over, as you can see in this map. I come from Africa, where we have the African Society for Sexual Medicine. And depending on where you are, you can see all the affiliated societies. Next. I hope as many of you are subscribed to some of our journals. There are 4 journals, and if you are interested in knowing current research, discoveries, ongoing research, methodologies for treatment, and so on, this is the place to go. So you can log into the ISSM website, you can register, and you can be getting these journals. You can also publish with us. Next. So the program today, we will have 3 speakers. I just want to quickly introduce the speakers. We have the first speaker, who is Stephanie Buller from the US, talking about neurodiverse and sexual neurodivergence and sexual function. Stephanie is highly respected psychologist, a certified sex therapist, and supervisor and a fellow of the International Society for the Study of Women's Sexual Health. As the president of LearnSexTherapy.com by the Buller Institute Incorporated, she leads a premier educational platform offering APA, NBCC, ASECT, and California BRN approved continuing education for mental health and healthcare providers. A prolific author, Dr. Buola is best known for her widely used inclusive textbook, What Every Mental Health Provider Needs to Know About Sex, which is in its third edition now, which has become an essential resource, recognized for creating a sexological systemic model. Her work has been highly influential in sexology. She serves as a reviewer for esteemed academic journals, including current reports in sexual health, ensuring the advancement of evidence-based practices in sexual health and therapy. Dr. Buller is a sought-after speaker in many forums. She represents a leading presenting in a leading conferences such as ISSWSH, ASECT, ISSTAR, and the California Psychological Association. Her expertise has been featured in major media outlets, including The Atlantic, Prevention and Women's Health. Previously, she practiced at a major regional hospital where she specialized in the intersection of physical, mental, and sexual health. Today, she provides expert consultation and supervision in sex therapy and sexuality counseling, guiding clinicians in delivering compassionate, informed care. So that will be our first speaker. Our second speaker will be Michelle Tepper. Dr. Michelle brings 43 years of personal experience living with a spinal cord injury to his role as a sex researcher, educator, coach, and servant leader with profound understanding of the challenges and triumphs faced by individuals with acquired disabilities. Dr. Tepper has become a passionate and influential voice advocating for sexual health and intimacy within the community. Dr. Tepper's dedication to improving lives is evident through his extensive contributions to the field. He has published research on sexuality education and counseling in SCI rehabilitation programs, pleasure and orgasm in people living with spinal cord injury, and sexual health care for wounded warriors. Additionally, he developed the curriculum providing comprehensive sexual health care for people with spinal injuries. Continuing education for healthcare professionals that was funded by the Paralyzed Veterans of America Spinal Cord Injury Education and Training Foundation is part of what he's done. He's also the author of Regain That Feeling, Secrets to Sexual Self-Discovery, and producer-director of the award-winning documentary Love After War, Saving Love, Saving Lives, now streaming on PBS. Dr. Tepper's robust educational background includes a bachelor's in business administration from Bryant University, a master of public health from Yale University, a PhD in human sexuality education from the University of Pennsylvania. This diverse foundation equips him with unique expertise to drive meaningful change and connect individuals with disabilities, their families, and caregivers to vital resources and support. Dr. Tepper lives in Atlanta with his wife of 40 years, Cheryl. They have a 29-year-old son, Jeremy. Now I realize my video is fluctuating. I don't know why. The third speaker today is from the Netherlands, Wat Ganoten. He is an MD, a psychotherapist. He's a retired senior lecturer in medical sexology at the University Medical Center of Rotterdam and Utrecht in the Netherlands. For 2 decades, he was consultant in physical rehabilitation sexology. He loves teaching. Between 2010, sorry, my video. So between 2010 in Oxford and 2023 in Budapest, he took care of this topic in ISSM School of Sexual Medicine. So we have very, very high-level speakers today, very experienced, both academically, in clinical work, and also as people who have lived experiences. And we are looking forward to a very, very interesting session. Next slide. So I know there will be many questions arising as we go through the presentations. Please submit your Q&A through this button shown here. I hope you see this Q&A, not via the chat. Be sure to add the name of the speaker to whom you are addressing the question. We will have the Q&A session after all the presentations are done. Just a reminder that this webinar will be recorded and made available on demand through the ISSM website. Next. And so we start off with our first speaker. Please welcome.
Yeah. Oh, thank you so much. I'm very happy to be here today. There's a lot to talk about, so I'm just going to jump in. Next slide. Next slide. Here are the objectives. I'm not going to go through them, so next slide, please. And let's just start here. But I want to say one more thing, which is I am a PsyD, a doctor of psychology. I'm not a PhD. And so my training is to do review of the literature, take what I've learned into the clinic, see what works, what doesn't work. Ideally, there would be a feedback loop to the researchers. Unfortunately, that has not been the case most of the time. But in any case, so that's what I'm here sharing with you today. So in talking about people who are neurodivergent, we'll just start with the place of prevalence of sexual dysfunction. The 39% of males and 43% of females who are neurodivergent report sexual dysfunction. Among the population of those with who are, on the autism spectrum, people who are AFAB have higher rates of sexual problems than neurotypical females, and people on the spectrum who are AMAB have higher erectile dysfunction rates than neurotypical people. And I will say, just clinically, I've worked with I don't know, maybe hundreds of people who are neurodivergent. So, and I am also neurodivergent myself. I have ADHD. Next slide. So just quick definitions. Neurotypical, somebody who is neurotypical or NT does not display neurodevelopmental disorder traits. That's it. Someone who is neurodivergent or ND is someone who has ADHD, autism spectrum disorder, and learning disabilities. And the reason I'm presenting on both autism and ADHD is because there's a lot of overlap between these two disorders. And I think we're still trying to understand exactly what we're looking at. Learning disabilities, I could do an entire hour, 2 hours on learning disabilities and sexual health, but we'll limit it here. And then there are some neurological conditions as well, and a great overlap with mood disorders, anxiety disorders, OCD, and sensory processing issues. And of course, that can show up in a sex therapy or sexual medicine practice. So somebody complaining that they don't enjoy the sight, the smell, the taste, the feel of sexual stimulation. and may have trouble getting aroused. I once had a client who made his wife, and I do mean made, his wife wear a latex cat suit all the time because anyway, that's what he wanted. And it actually led to the dissolution of the marriage. So he had sensory processing issues. That was his solution. Next slide. So what are the barriers to sexual well-being in neurodivergent individuals? Well, first we often have difficulty with executive function, carrying things out. Especially people with ADHD often have poor ability to plan ahead. This means that practically in the realm of sexology, that can mean not looking for times to have sex. It can mean not preparing ahead of time and having the lube available, not picking up prescriptions for contraceptions, forgetting appointments for that, not planning to have safer sex, which can lead to increased STIs and unplanned pregnancies, disorganization, and having a hard time like making time for a relationship can be a problem. The next point is emotional dysregulation or difficulties regulating emotions. And, for example, people on the spectrum sometimes appear, because they can appear stoic and not very emotional, sometimes that means that what's going on internally is not really observed and not understood, and they can in fact be very sensitive, and they may hold things in because they don't know how to appropriately bring things up, and so they may have an explosive episode. And then it's not uncommon to do the opposite, to kind of withdraw emotionally and shut down emotionally. And so this can make relationships sometimes challenging for them. Sometimes the partner is the one who is complaining that, my partner is so sensitive, I don't know how to give them feedback, for example, in terms of sexual activity and so on. I already said a little bit about the sensory sensitivities, and these are often clients who present with something of a OCD presentation, worrying about the taste of saliva, or if performing oral sex, the taste of the genitals, the smell of the genitals, and so on. So that's something that you'll need to work with and really tailor if you do sensate focus activities with this population. Sometimes you really need to tailor things, and even I have referred people to an occupational therapist to help them with more sensory kinds of activities, touching things, or being recipient to different textures and kinds of touches. Often these are people that, like, if their socks aren't on correctly, they go nuts. So then you bring in like somebody else touching them or touching somebody else, and that can create a lot of misunderstandings and difficulty with arousal and not very fun sexual experiences. So that's a very important one to remember. Social stigma and shame. So, they're not neurotypical. So that means that they are different. And different in our culture, or really in society as a whole, different is seen as weird. And so they feel weird. They think that they're weird, and they're sometimes treated as weird. And so, they have a hard time with self-esteem. That can put them at risk for entering into relationships with people who may not be the healthiest for them. And then there's shame. So if they are interested in uh, kind of more novel kinds of sexual experiences, whether that's kink or just, the cat suit example would be one of them. I don't think he was ashamed, but anyway, those kinds of things, to have some shame around that. There was a study that I gave you a lot of references, but there was a study of women with ADHD who engaged in kink or had multiple partners. And they specifically said that they didn't want to be shamed by healthcare providers for their activity or the partners, and they wanted support to figure out how to enjoy things in a safer way. And communication challenges, sometimes people who are neurodivergent aren't so in touch with their emotions and what they want and what they need. They're frequently in their heads and not in their bodies, so they don't know what it is that they like, and that makes it hard to understand what a partner may want or need. And so, these are all things that can be showing up in practice. Next slide. Biological influences on health. Here again, I could spend hours on this, but we know that the number of people assigned female at birth who are going through perimenopause are frequently first diagnosed with ADHD at this time. It's because estrogen and especially helps with concentration and memory. And so that they start to become more disorganized and forgetful. And so, the HRT can be very helpful, but they also, I think, are helped by an appropriate diagnosis of ADHD. Like, oh, I see, I've had this. I've always had this, but I've been able to compensate. But now that I'm low in estrogen and dopamine, I'm having a hard time. Women who are neurodivergent may also see fluctuations in their ability to concentrate around the menstrual cycle and changes in the menstrual cycle. Then there's also a big topic, prenatal testosterone exposure. It can be, is perhaps linked to neurodivergence and diverse sexual orientation and gender identity. So this is very interesting, and I think that a lot more study needs to be done. But I know in practice, when I began seeing people who are on the spectrum, how many of them were identifying as transgender or agender or gender queer. And I thought, well, what is going on here? What is the link? And this may be what it is. Going on to neurotransmitters, I think everybody is on the dopamine bandwagon. Certainly, we have a lot of influencers, and gosh, the influencers around ADHD, I'd listen to them, and I'm going, well, that's a very broad generalization, and kind of drives me nuts. And everything is all about dopamine, and that, trying to chase it, the person with ADHD chasing the dopamine. Well, it's really much more complex than that. It's not just the dopamine, but it's the serotonin, it's the norepinephrine. And, there are ongoing studies about what actually is going on neurologically. And I don't think dopamine tells the whole story. And then, of course, last point here is amphetamines. So I think sometimes with somebody who may be compulsive or impulsive, there's some thought that if they take amphetamines, that it's going to make it worse. There's no clear link here. And many people who are neurodivergent are also on antidepressants. So you have to look at the possibility of impact on sexual function. The other thing with amphetamines is that for some people with ADHD, they find that timing of their medication can help with sexual activity. So to have some medication on board helps them stay focused and in the moment and be more attentive to their partner and have an easier time with arousal. And others don't find any connection at all. So next. I think there is a kind of a I'm looking for the word, but like a misunderstanding or not a clear picture about people with ADHD and increased masturbation or novelty seeking, and maybe having compulsive sexual behavior disorder. And there's really not a consistent link. I mean, some people, it's like, just like in the general population, some people masturbate more than what is maybe common. And some people are into kinky sex and novel sex, but there doesn't seem to really be necessarily an increase with people with ADHD. And so that's something like um, not to have a bias when somebody presents who has ADHD, and not go to, oh, if you're masturbate daily, it's because of the ADHD. That is not necessarily the case. So you can look at other things like just enjoying masturbation daily. So anyway, there are two flavors of ADHD. Of course, there are those who are hyperactive and on the go and can't sit still and so on. And then there are the inattentive types who space out and really have difficulty focusing and remembering things. The impulsivity is a kind of a hallmark of ADHD, and that can be really problematic in terms of risk taking, and at higher risk for contracting STIs or having an unplanned pregnancy. So that is something to keep in mind, and to give appropriate counseling, and not to be to make sure not to be shaming or like a parent, but to just be matter of fact and say, like these are it like to enjoy sex is wonderful, but let's talk about doing so safely and what you need to be doing to take care of yourself. And this also has to do with partners. The thing is that because the risk taking, that sometimes people find inappropriate partners and really struggle with relationships. Uh, for the inattentive type, there can be inattentiveness during partnered sex. They're spacing out. The partner is like, where are you? Where did you go? The person themselves is saying, I don't know what happened. I was enjoying myself and suddenly, I lost my erection, or suddenly I just wasn't into it. So that can be happening. And there are things that can be done. Bringing in some novelty can help. Changing positions more frequently, using toys or a different kind of lube, or changing the place where sex is taking place, or doing something different, having a different kind of date night, or, something of that nature. And we also know that there are a higher prevalence of LGBTQ plus identities. And of course, we always want to be affirming in our practice, but just be aware that that questions may come up, or people may be questioning and so on. We want to be supportive of them. Next. Then clinical observations, people on the spectrum, historically, they are often viewed as being asexual. They may, sometimes they even will dress in a way that is kind of agendered. And so they're seen as asexual. They may not understand their own sexual impulses or desire, and or may not understand arousal. They may not be connected, especially to their sexuality, and for that reason may not appear to be interested in sex. But we know that, excuse me, I need a sip. We know that may not be true. One of the very sad issues that I've seen, I've had parents of teens and young adults get in touch with me because their uh, kiddo on the spectrum is looking at pornography, and the kind of pornography they're looking at is troubling to the parent, maybe very violent kink or something of that nature, or they get into cosplay, and the parent isn't understanding of it. And then they get into groups, online groups, and there's a lot of worry about their kiddo being exploited because they don't really understand social relationships and or that they may exploit. And that's the other thing, is that sometimes because they don't understand social cues and sometimes don't understand how another person feels, they may and they may not understand their own internal conflict between the sexual urge they have and the social navigation. They may act out inappropriately. And so they need specialized sex education. I know within ASECT, we have educators who have special materials that can be purchased online to help um, uh, educate not just the person on the spectrum, but also parents and caregivers about sexuality with this population, so that everybody can be open and communicating about sex. So we can go to the next slide. Do you want to mention strengths? We're talking about some challenges here, but there are strengths. So those with ADHD, their superpower is the ability to hyper-focus. You give somebody with ADHD a project that is interesting to them, they will go down a rabbit hole and you won't see them. You may not see them for a while. There's cognitive flexibility and creativity. So they, if they run into a problem, they tend not to be too bothered by that, and they'll find ways to, or hacks, I would say. Like I am the queen of hacks and figuring out how to do things more quickly or efficiently. There's a lot of creativity as well. People on the spectrum have great attention to detail. They go into engineering and medicine and the applied mathematics and so on. They have great pattern recognition, and that can be very helpful in problem solving as well. And they like to live with integrity and authenticity. And I don't want to paint too broad a brush, because I've had clients on the spectrum who are definitely deceitful. But in general, they tend to be like very truthful, almost painfully truthful, which some partners don't really dig. So anyway, but those are some strengths. And next slide. So practical treatment considerations: as with everyone, we want to be trauma informed and provide affirming care. And, one thing that is also very, very concerning is that it appears, so people with ADHD sometimes are scapegoats within the family, also people on the spectrum, but they can be scapegoats and having experienced higher rates of childhood abuse. And when they go into adulthood, they can continue to be at risk because they don't necessarily understand what is happening, or it's a repetition compulsion. And so, they are at risk for sexual exploitation and sexual assault and rape. So, and put that together with the low self-esteem and the shame. If you have low self-esteem, sometimes looking for validation through sex and love, hopefully love, but often maybe it's just something sexual and they didn't even realize it. So there can be quite a bit of trauma that you want to address, and to be affirming and to let them know that they're not alone, they're not the only one, and here are some reasons that here are some connections perhaps to think about, and give them support around those unfortunate activities. And then you want to give them support with planning and communication. I know I've spoken to groups of physicians about ADHD and sexuality, and like I was in with live group and I could see light bulbs popping over people's heads, and they're going like, oh, I never even thought about this one. Somebody said, oh, we're all thinking about that patient who is always late for their appointments or who's haven't followed up with filling a prescription, or here they are again with another STI or whatever it is. So if you recognize, or you know that the person has ADHD, to say, let's sit down together and figure out a plan, open up your calendar and or your to-do list and write down what you need to do to follow up with this. And then you're going to make a follow-up appointment before you leave to address this, and be really clear with your communication and make sure that they're understanding it. And then things that can be helpful with sex, just arousal and pleasure. Mindfulness can be helpful. However, a lot of people who are neurodivergent have problems with mindfulness. And so, there are other things besides mindfulness. There's walking meditation, for example. There's listening to music. There's guided meditation, all kinds of ways to have a meditative activity or a mindful activity. Sensate focus, to modify that for the person. Sometimes they need to go very slowly because of the sensory issues that they have. And so just starting out with just hands and sensate focus with hands, and then maybe arms, and really talking about pressure and temperature and texture, and getting feedback and listening to each other's feedback. And then medication timing. And this can be true with the amphetamines, but also with antidepressants. And that's, I'm not a psychiatrist, so I don't, I just suggest it to the client and they can take that to their provider. And then, you want to get partners involved, but you don't want them to become parentified. And it's really uncanny how often somebody with ADHD partners up with somebody who's kind of more OCD, and the person with, of course, it's like, the person with more of OCD or personality, obsessive compulsive personality, how they are driven nuts by the person with ADHD. And the person with ADHD, it's like they want someone to help them get organized, but at the same time, it's like, stop, you're like my mother. And anyway, so, you really have to acknowledge that dynamic and help them figure out how they're going to navigate those dynamics in their relationship. So next slide, which I think is my last. Next, thank you. Take-home messages. So, sexual well-being is vital in neurodivergent health. Of course, there are some people, especially those on the spectrum, who in fact are asexual, but even then, to be validating and affirming of them, and say, okay, well, you do have a sexuality. It happens to be you're asexual. Some people consider this to be an orientation. I don't think it's well understood, but sexual well-being is vital in neurodivergent health. Hormones play nuanced roles in understanding ADHD, especially, and inclusive personalized care helps to reduce shame and being trauma-informed. And neurodivergent individuals bring unique strengths to relationships. And I think if you are in a relationship with somebody who's neurodivergent, having a sense of humor is a requirement. I think that brings me to the end. Lots of references. Okay. Okay, thank you for everybody.
Thank you. And we move to Michelle now.
Hello, everybody. I see some familiar people here. We can get started with the next slide. So disclosures, I offer an online micro-credential course for CEs in partnership with the Chicago School called Providing Comprehensive Sexual Health Care for Persons with Physical Disabilities. And if you scan that, it will take you to the registration page. Next slide, please. So the why is it important to provide sexual health care and sexuality education to people with spinal cord injuries? So, the sexuality is a critical aspect of identity and quality of life for individuals with spinal cord injury. And just like everyone else, I guess we don't really have to convince the crowd here of that. Spinal cord injury has a direct, indirect, and treatment effects on sexual function, response, and expression. So it essentially can affect every part of our sexuality. Sexual health care is a critical component of holistic, patient-centered care, and sexuality is consistently in the top 3 priorities for people with disabilities. So there was a study by Kim Anderson, and so folks who are paraplegic, which means they have injuries below their neck, they have full function of their hands. Regaining of sexual function is their top priority. For quads like me who have problems with their hands and levels of injuries in the neck that affect more upper body and control, after regaining control of the hands, sexual function was number 2. And left untreated, sexually related concerns can lead to social isolation, loneliness, and depression. Even, suicide. I had one speaking in a hospital patient say, if I can't get a nut off, I'm going to kill myself. And in my work with veteran populations, we know that failed intimate relationships are the leading cause of suicide. So sexuality is a very important topic, and very important that we address it. Next slide, please. So I'm going to give you a summary of United States national survey that I conducted in my master's program at Yale. So this was done 35 years ago, and although it's an old survey, it's the only national survey directly of people with spinal cord injuries that I know of, and I've, stay on top of the literature. And whatever I tell you here, I'll have to say the length of stay, at least in the United States. When I was injured, I got 7 months. I wouldn't get 7 weeks now. And so the state of the sexuality education and spinal cord injury rehab programs is worse than it was 35 years ago. So the aim of my study was to assess the provision of sexual education and counseling services in spinal cord injury rehabilitation programs. And so this was a national sample of 458 individuals who were part of the National Spinal Cord Injury Association. And this was a mail survey. It was before the internet. And there were 251 completed responses. So people had to fill in their responses and mail them back, and received a lot of thank yous and questions, and actually spurred my going on into getting my PhD in human sexuality based on the results. I was heading towards being an administrator in a rehab hospital. So on the results of this study, only 45% of respondents recalled receiving any sexual education or counseling services during rehab. And that was defined as a brochure, a session, a class, a session with a person. And so less than half received anything. Like I said, the services provided varied significantly, from just getting a brochure or just a 45-minute class to maybe a doctor talking with them. only 48% of those who received services felt their needs were adequately met. So less than half received anything, and the half that did, or the less than half that did, less than half of them thought it met their needs. There was a gender disparity. So female respondents had about twice the odds of not receiving sexuality education or counseling compared to male respondents. And then, so this identified a gap. So this between the services provided and the services desired by people with spinal cord injuries. Next slide, please. It's a continuation of the study. So this showed a need for comprehensive programs. Respondents indicated a need for more comprehensive and frequent sexuality education and counseling services. And there were suggestions to include early discussions about sexuality and a combination of sexuality education materials and peer support and professional awareness. Healthcare professionals should recognize sexual concerns as integral to the rehabilitation and strive to address them adequately. Next slide, please. So the barriers to providing sexuality education for health professionals, I mean, these have been around. They really haven't changed over the 35 years. This is a more recent study from 2022, but I could show you older studies showing you the same. Insufficient knowledge. When I was at Morehouse School of Medicine, we put together a curriculum for training health professionals. We knew that, you know, the average medical school had 8 hours of sexuality training, but it was mostly in reproductive health and STIs, not anything to do with, you know, sexuality in general or pleasure or orgasm. Lack of inadequate training. When I teach medical schools and I ask students, so a class of 50, how many people received a class in their graduate education in human sexuality? There's only a couple of hands that go up. Not knowing who's responsible for delivery. You know, and I'll talk about the need for policies later. Absence of teaching materials or appropriate educational resources. I think there's some out there, but there's a lack of knowledge about where they are, and discomfort discussing sexual topics because not everybody has been trained in this area. Next. So providing comprehensive sexual health care, what does this mean? It follows the comprehensive rehabilitation model, because I know we have comprehensive sexuality education, and they're very similar. So comprehensive rehabilitation model is holistic, it's patient-centered, it's interdisciplinary, and it's biopsychosocial, and I add emotional, relational, and spiritual. So it's really covers all aspects, different than comprehensive sexuality education. There's not so much of an advocacy component there, but we teach people to advocate for their own needs. And sexuality education should be introduced early. And I have a essay out there in the Journal of Sex and Disability on the fluid issue, but it should be introduced early. It should be available throughout the continuum of care because a lot of people aren't ready, especially when the length of stay is you know, 5 or 6 weeks these days. And I've heard more from women than men that it's overwhelming to think about it at that time period, but it should be introduced. People should know it's part of their rehabilitation, and they should have it available throughout the continuation of care. And it's good to use a mix of written material. So you definitely should have handouts, videos, and I have a paper on the use of sexually explicit videos in these kind of settings because that's a special technique. But there's a lot of videos that are not explicit. I have some on my drmitchelltepper.com with sexual positions and other aspects using vibrators. And there should be individual education and counseling should be available. It involves experienced peers in the discussions to enhance the educational experience. So I always, even though I have a spinal cord injury, I usually try to bring in a woman with a spinal cord injury when I'm presenting to get a different flavor, different aspect, because just because I'm injured doesn't mean I have the experience of every type of injury. Physicians should be approachable. In my survey, people would like to hear from their physicians first, and that's who they're least likely to hear from. You know, they heard from nurses, less likely, sometimes from psychologists. But when asked who they would like to hear from, they said either, you know, physician or anyone who's really interested in sharing that information. So physicians should be available for consultations, and I'll talk next about this interdisciplinary team approach. Different people on the rehab team should have different roles in providing that care. Comprehensive education should include a focus on pleasure, body image, sexual self-assessment, positioning, practical considerations like bowel and bladders, and in addition to the effects of spinal cord injuries on function, response, and control. And often people use Jack Annan's implicit model, or, you know, it was updated to the explicit model for a counseling framework. And I am a big fan of the sexual rehabilitation framework. And there's a reference here, a multidisciplinary approach to sexuality and fertility and rehab. So you could refer there for more information on the rehabilitation framework. Next slide. So take-home messages. Sexual health is a top priority for patients. Sexuality should be, education should be holistic, patient-centered. Hospital policy is needed to establish standardized protocol. In the United States, there's the CARF, the Commission on Accreditation of Rehab Facilities, that says you should include sexuality education and healthcare, and so there really should be standard protocols. Establishing a sexual health team is recommended. Like I said, I preach an interdisciplinary approach. Happy if you could get to a multidisciplinary approach. We should provide regular staff training, very important to reduce all those barriers. We could consult the clinical practice guidelines for detailed content and recommendations. A number of us in the field spent years developing these guidelines, and I believe I had a reference earlier up on one of the earlier slides on how to access those. Consider incorporating the sexual rehabilitation framework into your setting, and make comprehensive sexual health care available along the continuation of care. So I believe I got this in my 15 minutes. Happy to address any of your questions. Thank you.
Okay. I guess I will.
Yeah, please proceed.
So I'm going to continue. Good afternoon, good morning, good evening. I'm Rutger Jan Otten. Next slide, please. I have decided to separate sexual habilitation in young people with neurological disturbances and the rehabilitation when developed at a later age. And as you see, I have nothing to disclose. Next slide, please. People with a disability, they do have sex, or they like to have sex, just like other people. Next slide, please. And they have some arguments which are even stronger than for, let's say, common people, because they miss already so much. And sex is a boost for human identity, for male identity, and for female identity. And very physically, it can reduce pain. It can cause muscular relaxation. with, for instance, less spasm after excitement or orgasm, which is very important in many neurological diseases. Next slide, please. Among the many emotional and physical health benefits, gradually the researchers are discovering that there are indications that some aspects of sexual expression have neuroregenerative potency. In other words, having sex could be healthy, both in terms of care and in terms of cure. Next slide, please. So that's a little bit the principle of what we call physical rehabilitation sexology. That's maximizing the sexual and erotic function or abilities of the single patient or of the couple in spite of existing or developing impairments. And that is a kind of a new specialization in medicine. And there are clear examples in Canada, Sweden, the Netherlands, France, and Greece, for instance. Next slide, please. So first about the adults, you see here their sexual functioning, that everything goes well till they get a stroke or an accident, and then they need rehabilitation, sexual rehabilitation. That's very different from the youngsters. Next slide, please. Here you see youngsters with different neurological impairments. They have not yet started a sexual life, and we don't know what will happen to them. So what they need is not rehabilitation, but habilitation. I'll talk about that a little bit more. Next slide, please. So here a little bit guesstimates about disturbed sexuality and intimacy. Of course, you have people who have that disease serious and others have it in a little way. But in average, we saw that 60% of the people with cerebral palsy, 60% of the people with spina bifida, and more than 70% of the people with neuromuscular diseases had disturbed sexuality and intimacy. Many of those serious cases don't live at home. Next slide, please. And then those people who don't live at home, but also the ones who live at home, what they need is comprehensive sexuality education. That is one of the WHO parameters of sexual health. And what those youngsters need extra is impairment-specific fine-tuning, partly regarding sexuality functioning, but also regarding contraception and STI prevention, and also regarding sexual abuse prevention, because this is a group which very easily is the sitting ducks for people who want to abuse sexually. And then what we have to do is create opportunities so that they can be young, that they can experiment, and that they are enabled to develop their own sexual choreography. In England, Tuppy Owens and her group did that very much, and they wrote a book about it. And that's a lot of is about habilitation, learning to be a sexual person in a different way than what average people do. Next slide, please. And then we have to be aware that sexuality is an integral part of sexual health and well-being of all people, according to WHO. Even those ones in a wheelchair, even those ones who can't move properly and sometimes can't talk properly. Next slide, please. Now, small group that are the people with the muscular disease. In youngsters, then you have the men with Duchenne muscular dystrophy. They will die at a young age, just as some people with young people with cancer. And then we hear sometimes, I don't want to die as a virgin. And imagine what it means if you are in the helping profession and you get this request. Next slide, please. Are we prepared to inquire about a sexual bucket list? And on the other hand, are we prepared to deal with such requests? Think it over. Next slide, please. Now let's go to the grown-ups, to the adults. Here again, the guesstimates of disturbed sexuality. That's going between 60 and 100% in case of spinal cord injury. Now let's make two groups of them. Next slide, please. First, the ones where you have a one-time accident, either a traffic accident or a brain accident or a stroke. And then what they need, because suddenly their function goes down, what they need is kind of repairing rehabilitation, repairing sexual rehabilitation. The other group, that is the people who get a disease, which is not a one-time thing, but something which goes worse and worse and worse, like in the muscular diseases or with Parkinson or MS. They need, when they go down in their functioning, they need again and again our support. We could call that palliative rehabilitation. Next slide, please. Now be aware, I will address only some of the relevant elements of those different situations, because in our job, it's a full-time job in physical rehabilitation. There's a lot of information, but I take only some pieces out of that. Next slide, please. We start with multiple sclerosis. That's a degeneration and disturbed isolation of nerves and nerve fibers. Next slide, please. And it starts, that's important, it starts in young people and much more in women than in men. Now, a very common symptom in MS is that the stimulation of the genitals in the woman doesn't get reported to the center in the spinal cord. And then they can't get an orgasm with a normal stimuli. And then what we could tell them is try a strong vibrator, which is sometimes good enough just to repair that complaint. Next slide, please. If you go to the man and male orgasm, it's difficult for them to have an orgasm regularly, because in the same way, because of the damage to the pudendal nerve, they can get ejaculation problems. Sometimes unejaculation, that they don't get sperm because of autonomous damage, or they get the sperm getting into the bladder. And they can get premature ejaculation, which is a very common complaint in sexual medicine. Next slide. But what is usually forgotten by the sexual medicine specialists, that premature ejaculation is a very common complaint in people with various brain damage and frequently with impaired control. It happens in multiple sclerosis, in stroke, in traumatic brain injuries, in Parkinson's disease, also in Parkinson's medication, in brain tumors, and in Whiplash disease. Next slide, please. Now some other MS troubles. They get disturbance of the motor system, which means they will be tired, they have less desire, and they can have troubles with positioning. They can get direct damage to the erection and lubrication as well. They get damage to the continence mechanism, with shame and fear, and if you're afraid to lose urine or stool, then it can be more difficult to get an orgasm. In 65%, they have moderate to serious urinary problems in MS. And in 1 out of 7, that's the primary complaint in MS. Next slide, please. Now a little bit about urinary incontinence and sexuality, not only in MS, but there's in many other diseases, in Parkinson, in stroke, you have that as well. When there is female urinary incontinence, it happens as well during sex, both in penetration and in orgasm. And that is extra disturbing in oral sex. Now, for a small amount of people, oral sex doesn't fit in their love map, but it's in the common love map of the Western world in 1/3 to 3/4 of the heterosexual encounters, and in 95% of the MSM encounters, where men have sex with men. That's the number one in the love map of MSM, which is not, I was always thinking that it was anal sex, but anal sex is only the third. Oral sex is number 1, mutual masturbation is 2, and anal sex is only number 3 in the MSM love map. Next slide, please. Now, when we have to deal with physical impairment or chronic disease or cancer, I think we sexual professionals have to develop a medical dirty mind. An example in MS is asking, do you also lose urine during sex? And did losing stool maybe also happen during sex? And did it maybe happen during oral sex? Because patients nearly never will tell such experiences spontaneously. However, they can be very relieved when this is addressed. And if they never had it, maybe they will feel happy that at least that didn't happen to them. Next slide, please. Now, general treatment recommendations in MS, but also in many other diseases, when the female patient is not in the mood for penetration. Now, if she has a male partner, the male partner, of course, has a lot of stress because his girlfriend or his wife is having a serious disease. And then when men have stress, they frequently use sex to reduce the stress. And they need an orgasm for that. Now, that's a common problem if the couple didn't learn how to do that without penetration. So next slide. So this is what we consider now more and more is recommend intimate masturbation, where in this case the man can cuddle with his wife and then make himself to orgasm by masturbating. It can be the other way around as well, when, for instance, the man has a Hodgkin lymphoma and is very tired, and the woman wants to help him and then makes herself to orgasm, which can make him very proud and make him sexually enthusiastic as well. Next slide, please. Now I change to stroke or cerebrovascular accident. Next slide, please. A very common problem then when the man has got a stroke, that he is complaining of no erection, which is of course expectable because getting a stroke is a problem of the vessels, and erection problem, ED, is also a problem of the vessels. On the other hand, his wife is frequently fearing to have sex because could a stroke not happen again during sex? Now, a very important answer to that is in the next slide. Next slide, please. Because in the ischemic stroke, when a part is, it was not a bleeding, but there's a kind of a spasm in the vessels by which part of the brain doesn't get oxygen. That is the great majority of stroke. That will not happen during sexuality. When there is a bleeding in the brain, which is in about 1 in 10, that can happen during sex. And then it can be important to teach the man to walk towards orgasm without much tension in the rest of his body, without bringing up his blood pressure too high. Next slide, please. Now, what happens also in stroke is they get a hemiparesis. That means if you have the stroke on the left side of your brain, the right side of your body has motoric problems and sensibility problems. That means he can get spasticity, he can get contractions, he can have pain, and he will have loss of power, and then he can't position properly. If he or she doesn't, they get sensibility problems, they lose sensation, and they lose sometimes important erogenic zones. Next slide, please. And then they have also change in personality and behavior, which that can be very difficult when, let's say, also mental changes which can give more irritation in the partner relationship. It can give disturbed communication, which is very different between male and female. If the man doesn't talk, is a major problem for the majority of female partners, while if the women doesn't talk, is usually not a problem for the male partners. And they have as well disturbed filter function. That is partly the reason for premature ejaculation, but also control over the sexual impulses. That means man, after a stroke, can become grabbing the breasts or the buttocks of the nurses. But it happens also in females, which we usually tend to believe that is less bordered, less going over the borders, but of course it's in fact the same rotten thing. Next slide, please. Now we change to Parkinson. That's a disease with many different symptoms, included erectile dysfunction, included bodily changes. And the most important reason for sexuality changes is getting a low dopamine, because the brains make no more dopamine. And that means that your sexual desire and your sexual pleasure and the fun will disappear. And then what we do, we give medication, next slide please, with dopamine and dopamine-like medication. And then the desire is returning, but then a real problem can be that the desire becomes too much. Women sometimes say about her husband, he's coming to me like an animal. And therefore, it's always very important to ask the female partner how sex is going, because she will honestly tell that it's not going well. But don't forget, also women can have this too much sexual desire because of the high dopamine level. And then the physician, the neurologist tries to keep the body enough capable of living, but in the same time desire gets back in a very high way. Next slide, please. So that brings me to the take-home messages. One is physical impairment may decrease function, but doesn't diminish to be a sexual being. And the second message is don't overvalue function. It's more important to invest in adaptation, to invest in pleasure, and to invest in intimacy. So asking about erection is not always wise, at least not asking about erectile dysfunction. And the third one is let's all be aware of our own comfort zone. Next slide. Because the sexual life of many patients flows at the edge of our comfort zone. That's my last slide. Thank you very much.
Thank you. These are very exciting and also touching presentations. We have a few minutes for Q&A, and we already have 2 questions. The first one is, would you mind shed some light on how you'd tackle how disgust sensitive partner, how to manage disgust when you have a sensitive partner. So yes, go ahead.
Yes, so that is a really great question. I think one of the things that comes to my mind immediately is consent. So if somebody really has disgust, you have to have consent that this is something that they want to work on and they want to change. So you cannot make somebody like something that they simply are not, either don't like, or are not ready to figure out a way to be more comfortable with something. I think for those who are interested in changing, so one of the things that I do is say, let's just start with feeling neutral about certain sensations. So for example, not wanting to have a certain body part touched, or not wanting to see a certain body part. So let's just focus on visual, for example, and, to kind of collaborate on some kind of plan. So maybe they, at first, are they willing to just look at a diagram, a drawing, a plain outline of the genitals, for example, and look at the anatomy? Are they willing to do that? And if they say yes, then you can do that. If you want, you can do that with them and just have them talk about their feelings of just looking at the diagram and what comes up for them and so on. And then you could go to looking at maybe a photograph, something that is not so much erotic, but more towards the medical, something also, again, maybe showing more of the anatomy, and talking through that. So you could do a stepwise kind of approach, and always collaborating with them if they become overwhelmed, to tell them that they have the they can say stop or hold on, let's take a pause. I would teach them relaxation techniques as well, so that if they become overwhelmed at some point, you can help, they have a way of to regulate themselves. And I would do some CBT also, like what thoughts are coming up for them, and testing those thoughts out and seeing if they are malleable to change. So those are just some initial ideas.
Okay, thank you. So there is a request if we could share the email addresses of the speakers. So I think our speakers can feel free to write their emails in the chat box. But there is another question to what? Thank you. Do you have stats on women having sex with women for oral sex?
Sorry, what is the question exactly?
Do you have statistics on women having sex with women for oral sex?
I have no statistics, but I think women who have sex with women, they will have oral sex at least more than 90%. But they have also many other ways of sex. We tend to believe that they just are tripping crotch to crotch, but they have many more different ways. They have also vaginal sex. More than 90% have vaginal sex. Put fingers or dildos in the vagina. A high amount also has anal sex, and a high amount has, of course, oral sex. So they are not very different from what the average heterosexual women, at least in Western society, is doing.
Thank you. Any other comments, members, panelists? Okay, so I think this has been a very, very insightful session. I think one question we have to deal with in this space is the issue of rights. Because sexual health, the right to sexual pleasure, the right to satisfying sexuality is a right. And the fact that some sections of society may be neglected or ignored is really an injustice. So we need to also do some advocacy around this, so that if, for example, people have disability or have an accident or a stroke, they have the right to care that includes sexual health care. Thank you very much, everyone. This has been engaging. This presentation can be found in the ISSM website. We have webinar recordings there, and it will be there, so you can continue accessing it from there. Till next time, thank you very much.
Thank you.
Okay, bye-bye.
Bye.
Bye.